Welcome back to the podcast, everyone. I'm Dr. Khan, here with the ever-precise Dr. Sara. Today, we're tackling a small patch of real estate in the shoulder that causes massive clinical headaches, the quadrangular space. If you think of the shoulder as a busy airport, this space is the restricted gateway for the most important VIPs traveling to the deltoid. Dr. Sara, how do we orient our students to this anatomical box?
Energy as always, Dr. Khan. To be precise, the quadrangular space is an intermuscular gap located just below the glenohumeral joint. For the boards, you must memorize the four boundaries. Superiorly, we have the subscapularis and teres minor. Inferiorly, the boundary is the teres major. Medially, it's the long head of the triceps brachii. And laterally, we have the surgical neck of the humerus. It's a classic four-walled structure.
I love it. I tell my residents to think of it like a window. If you're looking at the back of the shoulder, the long head of the triceps is the vertical divider. It splits the region into a square, the quadrangular space, and a triangle. But why does this matter clinically? Because if that window gets slammed shut, the axillary nerve gets crushed.
Exactly. And for those listening for exam prep, the axillary nerve is C5 and C6. But don't forget its traveling companion, the posterior circumflex humeral artery. These two emerge together from that space. If you see a question about a mass in the axilla or compression in the shoulder that affects both a nerve and a vessel, this is your primary suspect.
Right. Let's talk about that 64-year-old woman mentioned in our text. She falls down the stairs, severe shoulder pain, and her arm is just hanging there. When the clinician looks at her, that normal rounded curve of the shoulder is gone. It looks flat. Dr. Sara, what's the board answer for that loss of rounded curvature?
That is high yield. That loss of curvature is due to the dislocation of the humeral head medially, meaning it's no longer pushing the deltoid muscle outward. In this patient's case, it was a subcoracoid dislocation. This is a surgical emergency because the humeral head is now sitting right in the neighborhood of the axillary nerve. If that nerve is damaged, the deltoid muscle will eventually atrophy, making the shoulder look permanently square or flat.
And think about the physics there. The subscapularis and pectoralis major are strong muscles. They pull that displaced humerus even further in. It's like a tug-of-war where the axillary nerve is the rope getting squeezed. Now, let's say you're in the ER. You've reduced the dislocation, but you need to check if that nerve is still alive. You can't just ask them to move their arm. They're in too much pain. Dr. Sara, where do we touch them?
You look for the regimental badge area. This is the skin over the lower half of the deltoid muscle. The axillary nerve gives off the upper lateral cutaneous nerve of the arm. If the patient can't feel you touching that little patch where a soldier would wear a rank patch, that is a positive sign for axillary nerve injury. Why does this matter clinically? Because sensory loss is often the first and most objective sign of nerve trauma before muscle wasting even starts.
Great analogy. Now, what about the motor side? The axillary nerve doesn't just do the deltoid. It also handles the teres minor. So if I have a patient who can't initiate abduction for the first 15 degrees, I'm thinking supraspinatus. But if they can't get that arm up from 15 to 90 degrees, that's the deltoid, and that's our axillary nerve.
And don't forget the surgical neck fractures. The humerus has an anatomical neck and a surgical neck. The surgical neck is the weak spot just below the tubercles. It's called surgical because that's where the surgeons have to go most often. If a patient, especially an elderly person with osteoporosis, falls on an outstretched hand and fractures that surgical neck, the axillary nerve is the one at risk because it's literally wrapped around that bone.
It's like a vine wrapped around a tree trunk. If the tree snaps, the vine snaps. I had a patient last week who was the doctor of choice for his local sports team, and he was telling me how often he sees this in football players with heavy impact hits. It's not just the fracture, it's the hematoma or the swelling within that quadrangular space that can cause quadrangular space syndrome.
Exactly. That's a more chronic version. It involves hypertrophy of the muscles, like the teres major or the long head of the triceps, actually compressing the nerve. Athletes who do a lot of overhead throwing can develop this. They'll complain of vague shoulder pain and weakness in external rotation because the teres minor is affected too.
So to wrap this up for the listeners, if you see a patient with a flattened shoulder, numbness over the deltoid, or a surgical neck fracture, your brain should immediately jump to the quadrangular space. It's the gateway. If the gateway is blocked, the deltoid goes dark.
And to summarize the must-knows for the boards, 1. Know the borders. Teres minor, teres major, long head of triceps, humerus. 2. Know the contents. Axillary nerve and posterior circumflex humeral artery. 3. Remember the regimental badge area for sensory testing. And finally, recognize that the deltoid handles abduction from 15 to 90 degrees.
Perfect. Short, sweet, and clinically vital. Thanks for joining me, Dr. Sara. We'll see you all in the next episode when we move down the arm to the radial groove.